Can you guys, oops, sorry. Can you see my slides okay?
Yes, I can see them. Can everybody else see them?
Yes.
Okay, yeah.
So I am happy to be as formal or informal as is helpful for everybody. So I'm just going to kind of go through some slides unless anyone has any particular questions, and then we can talk about, any open-ended stuff at the end. So my name is Ashley Plant. I'm from Orange County, California, but now at Lurie Children's in Chicago. My journey to oncology is because I had gone pediatric cancer in my own family when I was younger. I lost a cousin at age 17 to leukemia, and I have a cousin who's now almost 30 who survived both liver and colon cancer before age 12. So a lot of my elementary and junior high days were spent at their bedside, kind of going through everything with them. So I knew from about sixth grade that I wanted to be a pediatrician. And then I got into just out of, seeing the need and wanting my research to hopefully be meaningful and impactful in some way. So started focusing on brain tumors specifically when I went to med school at Stanford. From Stanford, I went to UCLA for peds residency, and then Dana-Farber at Boston Children's for oncology fellowship and neuro-oncology fellowship. And there, I was also in a lab where we looked at how the immune system interacts with pediatric brain tumors specifically. And really my interest in research in general has been to address some of the things that I encountered being a family member of someone going through childhood cancer. And some of those issues included the side effects of treatment and wanting to kind of avoid the acute side effects and also long-term side effects of cancer treatment in children. So I thought it was really interesting to consider looking at our own immune system fighting cancer. Also, I saw a lot of inequities in how my cousins were treated when they were younger, between having a lot of means and having not a lot of means, and that making a big difference on the care that they end up receiving. So both of those are big passions of mine, and I'll kind of talk about how I've gotten to this point in the clinical trial that we're running at Lurie Children's. So I just wanted to kind of introduce you if you don't know Lurie Children's very much. Our program, let's see if this will switch. There we go. Okay, so this is our neuro-oncology program, just so you have some faces to associate with Lurie Children's. So Angela Wanders is our section head. It used to be Stu Goldman, who's since recently moved to Phoenix Children's. And our neurosurgery team, we have a new division chief, Sandy Lamb, who came from Texas, and Mike DeCyper, who came from St. Jude, who kind of leads our efforts in terms of the biopsy of the pons. And then our radiation oncology team. So just in a broad overview, I think you guys are all familiar with this, and this doesn't vary too much from institution to institution, but how we start out with DIPG diagnosis in general is kind of seeing how the presentation of symptoms has been, and then getting an MRI of the brain. We do get some special MRI techniques known as spectroscopy and perfusion to help us kind of look at pseudoprogression after radiation, and some other clinical trials can contribute to inflammation. So we use these features to be able to kind of tell what is progression, true progression or pseudoprogression. We have a big team. When we have a new patient diagnosed with DIPG, we know that really every aspect of care is important, including a team approach with child life and psychology. Our physical therapists do come onto our campus to help with DIPG families, and obviously focusing on all the needs for symptoms that might be there. We talk about biopsy, which, as you know, is very much optional. Dr. DeCyper kind of leads that efforts here and has a lot of experience with safe biopsy of the pons. We are able to use the tissue in a lot of different ways, including our own in-house molecular panels and advanced testing like methylation testing, and then obviously setting aside tissue if that's required for studies in the future. We then go on to radiation treatment at Northwestern, which is attached to our hospital, and then discussion of possible clinical trials and goals for the family. We do have re-irradiation as an option in the setting of recurrence, as well as clinical trials, both in the setting of newly diagnosed patients and also recurrent patients. So obviously, in talking about consideration of clinical trials, we are part of a lot of different pediatric brain tumor consortiums, as a lot of the larger hospitals are. And so we kind of balance what the goals are of the family, balancing the side effects that are possibilities with different novel treatments, and also, hopes and early data for efficacy. What the family's concerns are in terms of travel, if there are siblings involved who might be in school, thinking about eligibility, and trying to make sure that everyone kind of understands the idea of clinical trials and experimental therapies. So right now at our institution, we have a big group of consortium studies, which I'm sure a lot of you are aware of. So we are members of PNOC, the Pacific Neuro-Oncology Consortium, PBTC, Pediatric Brain Tumor Consortium, and as well as the CONNECT Consortium at a Children's National. We're also part of Kathy Warren's All-in DIPG Consortium from Boston Children's, the Remission Consortium, which is focusing on immunotherapy for brain tumors in general. And we're also a COG phase 1 program. So there are sometimes phase 1s from COG that are focused on brain tumors, and so we would have those open as well. We also work with industry-sponsored studies. The most recent one is a PDGFRA targeted therapy through Blueprint. So that's about to open there as well. So some of the tumors do have this PDGFRA change, and that would be a drug that would target that. So we'll have that open as well. And then I've initiated a phase 1 study for a novel vaccine, which I'll talk about in a little more detail. So I'm going to start with talking about how we got to this point. So getting to the point of opening the trial has honestly been a 7-year journey. So I feel like I've been talking about this vaccine for a really long time and not able to really give it to any patients. So we're super excited that we finally got this through and to the point where we will start enrolling patients. We're currently open at Lurie Children's. With the hopes of soon opening Children's Hospital Orange County. And I think after that, closely following will be Dana-Farber as well as Alberta Children's in Canada. And we'll be the lead site here. So I'll discuss what the treatment is, how the idea came about, what the design of the trial is, and some of the eligibility criteria, and then just things to consider moving forward. So in my journey of thinking about how the immune system interacts with pediatric brain tumors in general, I found it very fascinating that the immune system does recognize tumors initially, and somehow the tumor can send signals to basically turn off that immune response. So if there was a way to really capture that initial immune response and expand it, in theory, then the immune system could attack the tumor cells itself. So in looking at DIPG specifically, one thing that it's been really interesting is that there are very few genetic alterations that are highly conserved in this population of tumors. So we know there's variability, but there's a lot of genetic alterations that are very consistent. Can you guys still hear me okay? Okay, perfect. So the most common being the histone alterations, which I imagine a lot of you have heard about. And then they kind of predictably run with other molecular changes in the tumors as well. Like if you have histone 3.1, you might also have an ACVR1 mutation, PDGFR, running with one of the histone mutations, P53 with the 3.3, and a very small number. A lot of tumors can have a lot of different mutations, and those aren't necessarily conserved in all of the tumors. So DIPG specifically really is a good candidate for vaccines that are targeting these specific markers that are in the majority of the tumors. So this is from a paper that was published in Cancer Cell that looked at over 1,000 DIPG and diffuse midline gliomas. And they showed the same thing, that a lot of these genetic alterations kind of run together. As you can see, all of the big columns are kind of off to the left and together. So although there's variability with these other changes on the right tail of things, a lot of them are together and very frequent in a lot of these tumors. So it was an interesting start to thinking about, could a vaccine approach actually be useful in these tumors? So, in thinking about vaccines, a lot of people have been talking about vaccines in the context of COVID or other infectious disease. So, I think that it's very timely to talk about vaccines. A cancer vaccine is, slightly different than an infectious disease vaccine, but the concept is similar. That exposing the immune system to inactive portions of an infectious disease could make your body prepared to see the infectious disease in real time later on and have an appropriate immune response to it at that point that would prevent you from getting the infection. In cancer vaccines, the cancer is already there. So you're trying to teach the immune system to recognize specific markers on the cancer cells and in real time go and fight them. So there are a lot of different types of vaccines. They have different names: dendritic cell vaccines, peptide vaccines. The vaccine that we're using in particular, and the reason I sought out Agenus, which is a company that makes this vaccine backbone, is that this is a heat shock protein vaccine. So I know we don't want to go all the way back to Bio 101, but if you remember from your biology classes, heat shock proteins actually fold proteins and get them into their appropriate structure. But interestingly, we've found over time that heat shock proteins actually also interact with the immune system, and not just one arm of the immune system, but both the innate and the adaptive systems within the immune system. So the reason why that's important is innate immune system can respond really quickly to things, is a little less sophisticated. The adaptive immune system is where we get our memory and more specific targeting of the immune cells to either infectious diseases or, hopefully in this case, to markers of the cancer cells itself. So we have decided to call this vaccine DIPG Vax. Obviously, I'm not very creative. So RHC means recombinant heat shock. C is the official name of it, but you can think of it as heat shock protein is kind of the idea. So we actually make recombinant heat shock proteins from bacteria and then attach them to 16 different peptides that are unique to DIPG. So they include the peptides that would represent the histone mutation, ACVR1, P53, BRAF. So a lot of the common genetic alterations that are seen in DIPG. So 16 of them specifically will be attached to these heat shock proteins and be given subcutaneously as a vaccine. The idea is that the immune system would be trained and taught to go and attack these tumor-specific markers in the tumor itself. So that is the basically complete treatment of our lead-in arm in this clinical trial, which is the first 6 patients that will go on this trial. And they'll receive 8 doses of the DIPG Vax, separated 2 weeks apart, for 8 total doses of the vaccine. The requirements from the FDA, given that this is a novel therapy and also subsequent arms will combine immunotherapies, is that we actually have to enroll over 12-year-old patients first. So obviously that's a little bit challenging given DIPG is mostly diagnosed between the ages of 5 and 9. So that is going to be a limitation to our initial enrollment. But we will obviously advertise for people who do have older children who'd want to consider this, and then eventually we'll be able to enroll younger children as well. The next part of this will be a combination with a drug called balstilimab. And this drug and another one that I'll talk about called zalifrelimab, which are both tongue twisters, are basically medications that are considered checkpoint blockade molecules. And so the way that they work is they actually reverse off signals that the tumor can send to the immune system to say, hey, I see that you're trying to recognize and attack me. I'm going to put off an off signal so you no longer recognize me as foreign or a cell that should be attached so that I can kind of stay here and hide. But this drug actually blocks one of those signals called PD-1. It would block that off signal and hopefully allow the vaccine to continue to do its job. So trying to combine two different types of immunotherapy and also try to think ahead of what the tumor might do to respond to this immune attack, to try to resist it and try to see that ahead of time. So this is the next arm, which will include all three agents. So the vaccine, balstilimab, which is the PD-1 targeted checkpoint blockade, and zalifrelimab, which is a CTLA-4 targeted checkpoint molecule, which does the same thing. It's another off signal that the tumor can send to the immune system to try to evade the immune response. At the end, in order to not just assess safety, so a lot of the phase ones, the initial intention is to make sure that it's safe to give to children. Obviously, with a diagnosis like DIPG, we want to also be assessing whether or not it's effective. So we also built into this initial study to look at a dose expansion arm, which basically means keep enrolling patients at the safe dose that we find at the end of this study to see if we can change the overall survival from a 1 year overall survival from like an average of 1 year or 12 months to 15 months, so an extension of 3 months. So if it does that, then we would have approval to move forward with the phase 2, which would allow us to enroll more like 40 patients or more to confirm that this actually has efficacy for these tumors. So I'm happy to answer questions about that. I know that's kind of an unusual concept. The eligibility criteria is always the hardest part for me. We always want to make our trials safe, but we also want to make it as inclusive of all patients with DIPG as we can. So this is a newly diagnosed clinical trial. So if you have already gone past radiation and gone on to another clinical trial, we would not be able to treat patients in the setting of recurrence at this point. But if you either have just received radiation or no treatment at all, this might be something that a child could be eligible for. So we don't require biopsy. And, you know, we did that because we know a lot of our families at that point don't want to take on more risk necessarily and go straight into radiation. So this allows patients to still be able to enroll. If that's the case, they have not had a biopsy, then it would just require that their MRI is very convincing for DIPG and isn't kind of the atypical DIPG. If there's anything atypical or concerning that it might not be DIPG, then a biopsy would be required. And that goes for all diffuse midline gliomas outside of the pons. They would require biopsy in that setting. Completion of radiation therapy to the full dose is required. And that is actually because the radiation therapy should help the vaccine work. So the idea is to use the immunotherapy very close to radiation, because one thing that radiation does is expose all of these genetic alterations and markers that the vaccine is targeting. So it will work kind of synergistically or together with the radiation. The FDA did require that we wait 6 weeks after radiation to start just because of the concern for too much inflammation or pseudoprogression. So we've had to move, we had hoped to start 2 weeks after radiation. They have now required us to be at 6 weeks, which I think is fine. We know radiation effects go on for 3 months or more, but the sooner the better, obviously, with these tumors. Some of the exclusion criteria just that are important to mention is we don't allow the use of temozolomide during radiation. And the reason for that is because this is a kind of chemotherapy that kills off your immune cells. So it would make it less likely for you to respond. Most institutions don't use temozolomide anymore for DIPG because there was a study that shows it doesn't really do anything. But occasionally we'll have patients that come who have had temozolomide during radiation. The other exclusion criteria is disseminated disease. And the reason that we're required to add that is because sometimes if you have disseminated disease up front, that could indicate that your molecular characteristics are different than kind of the standard DIPG. And if we didn't biopsy you and that was the case, you might not have any chance of responding to the vaccine. So it's to limit kind of the more atypical or unusual profiles from entering the trial. This is kind of like a roadmap or a plan for how it might go to start on this study. So if your child is diagnosed with DIPG, we actually would do something called a pre-consent. So you don't have to agree to the trial right away, but agreeing to send some of the tissue for evaluation for this trial, along with using the tissue for other pathology and usual things. So we actually would send fresh tissue to Mariella Philbin at Dana-Farber, who does something called single cell RNA sequencing, which basically means she can look at the individual cells that are present in the tumor and give us information about whether or not you're likely to respond to the vaccine, and also how many immune cells are present at diagnosis in the tumor. So that just helps us as we're following along and seeing how patients respond to learn more about if something about their original tumor dictates those who respond and those who don't. And then standard radiation would start, and anywhere between 6 to 10 weeks post-radiation, patients would be able to enroll on study. They do the normal screening, which is basically evaluating and making sure there's no increased risk of side effects, more than we would expect, and then go forward with the vaccine treatment. This is Mariella Philbin, who I actually did fellowship with at Dana-Farber, and is a great scientist who focuses a lot of her time on DIPG. And she does this fancy types of experiments called single cell RNA sequencing, which is a more advanced way of sequencing individual cells and the genetic alterations present in those individual cells. And from our standpoint, what's also important is looking at the immune cells within the tumor itself. We are trying to also learn as much as we can along the way about how the immune system is responding to the vaccine, so that if there are things we can improve upon in the next round of developing vaccines, then we would have been able to learn from past patients how to help future patients better. So we're collaborating with a lot of people to do this work. So at Northwestern, Jason Miska and Catalina Chang are going to be looking at the blood samples of our patients getting the vaccine to see how the immune system is responding, and actually look and see if the T cells, which are kind of our attacker cells in the immune system, are actually responding to the peptides in the vaccine as we would have expected. Agenus has a special test to do the same thing, so we'll corroborate with their work. And then Aru Narendran is in Canada and has done a lot of work on something called epitope spread in breast cancer vaccines. So basically in breast cancer vaccines, they've learned that even though a peptide might say, go and attack tumor marker number 1, that actually the immune system can get revved up to also attack tumor marker number 3 and 4, even though they weren't in the vaccine. And that's an interesting phenomenon in which the immune system learns to attack the tumor cells even better than we originally planned. And we want to assess whether or not that's happening in our vaccine as well. So overall, DIPG-Vax is not a very creative name, but it's a novel heat shock protein vaccine that contains 16 peptides that are specific to DIPG, or diffuse midline glioma tumors. It's based on the data that came out of that initial study where a lot of families were willing to participate in research that might not benefit their child and allow biopsy of the pons. And that's how we got to where we are today. And that information is publicly available as a result. And we've been able to share that with Agenus to create this vaccine. This vaccine backbone has been used in other adult brain tumors, but this specific one for DIPG has not yet been given to any patients. Checkpoint blockade molecules will be combined in later arms of this study, and that's that anti-PD-1 and anti-CTLA-4 molecule that we mentioned. And the idea is to help support the T cells attacking the tumor cells and not allow the tumor cells themselves to submit off signals or turn off that immune response later on down the road. We hope this will also contribute to memory of the T cells so that they'll remember to keep attacking these tumor cells later on down the line. This is a phase 1 study, like most studies that are in or are for DIPG, which means that they're the first in-human or very early on in in-human studies. So there is a possibility that there are side effects that we don't expect, although we overall expect this to be a well-tolerated study. All clinical trials are optional. We'll give you kind of the best that we know about the data that we have, but we don't really have the answers for sure of whether or not it's going to work and how well it's going to work. In general, we use a team-based approach and try to support all the needs of our families that are going through DIPG treatment. Whether that's social work, we do have some financial support for travel, things like that. Obviously, the goals of care and talking to your physician about what might be the next best step for you is super important. I included the link. We are on clinicaltrials.gov now and open as of January 10th. So if you want more information there, or feel free to email us as well. And I just like to advertise all of our support because of these foundations listed here, that when companies didn't want to support our ideas, we were able to support the trial ourselves and get the vaccine donated to move forward with this phase 1 trial. So altogether, we raised $1.3 million to support this phase 1. And we're very excited that 7 years later, we're able to get this open. So thanks for having me, and I'm available for any questions you guys have.
Kill you. Hey.
Is someone trying to ask a question?
I have a question. Let me turn that on. Will you be open to treating a patient who's like 22, 23 years old, or is there an upper limit for the trial or compassionate use for the trial?
Yes, so we will be allowed on the study to treat up till 18. The company has not yet been willing to support compassionate use until we get a few kids on trial. And the reason for that is just they want to make sure there's no unexpected side effects before they go opening up compassionate use. But I've talked to them and they are very open to the idea a little bit further down the road.
Thank you.
Any
I
questions?
have a question. Thanks for being here for all the parents. Are the biopsies going to be pre-screened for PD-1, PD-L1, CTLA-4, the markers for those checkpoint inhibitor antibodies?
Yeah, that's a great question. So they will be, but it won't be in real time, so that we would know like before we started treatment, if that is the case, whether or not they're positive or negative. The interesting thing in brain tumors in general is we actually don't know if the testing correlates with likelihood to respond. So in adult tumors like melanoma, colon cancer, where anti-PD-1 agents have been very successful, they've been able to show that there's a correlation. But in brain tumors, even when those kind of agents have been used on other trials, it doesn't correlate with whether or not they tested positive. So we still are learning how to use those tests in general. So I think it's important to keep track of, but we don't know for sure if that means anything for patient response yet.
Yeah. I guess a more basic question is, what's the evidence that these antibodies work for these tumors, these brain tumors?
Yeah, so one thing that we've seen in other types of vaccines is that even if the tumor initially started not having PD-1 or CTLA-4 expression, specifically PD-1, that actually getting the vaccine and having some success with immune response will actually provoke the tumor to start expressing the PD-1. So even if at diagnosis it does it, it might be provoked by this immune response to protect itself and upregulate the PD-1. So ahead of time, trying to guess that that's what's going to happen and adding on the PD-1 antibody will hopefully help us to be able to get around that and keep that immune response going. So this is very much an extrapolation from adult brain tumors and other tumors that we've seen this phenomenon happen, and not wanting to kind of waste time in the setting of DIPG to learn that that's why our kids weren't responding to the vaccine, but kind of trying to circumvent that ahead of time. So we don't know for sure it's necessary, but we've asked to be able to use the combination up front so that we don't miss opportunities because of the tumor kind of outsmarting us down the line.
Yeah. Well, yeah, let's hope it works. I wish my kid were eligible.
And hopefully this will soon show that it's very safe. Like most vaccine studies have been very safe, and then compassionate use could be available on the other side of that. So the sooner I think we can get going, the sooner that becomes a real possibility. Thanks for your questions.
Actually, a number of patients use things like CBD or Boswellia and so forth. Are those going to be allowed? You just don't want to know about them, or is that a concern with this vaccine?
I will off the record say B. I don't think it's likely to affect the treatment, but when we're not sure of side effects, there's always a risk with combining other things just because we're not quite sure of what those side effects are and if they are worsened by the addition of those things. So there are plenty of supplements like turmeric, fish oil, and things like that that are known to have interactions with chemo. We don't anticipate that that kind of reaction should happen with an immunotherapy, but we're not sure. I would say the main concern with CBD is if you're starting it at the same time or up, kind of going up on the doses, that there's a chance that the pseudoprogression symptoms could overlap with some tiredness or other kind of central nervous system symptoms from the CBD, and that can make it very confusing. Obviously, we get an MRI to be sure, but I've gone through this a few times in working in California where we thought we were dealing with brain tumor issues, but it was just, doubling, tripling doses of CBD, usually combined with THC. So that would be the only caveat I would say. But yeah, technically all of the phase ones through the FDA do require a statement that we're not using additional supplements.
Thank you.
I have another question. The 16 peptides, are they going to be fixed for everybody, the same for everybody?
Yeah, so they are fixed, but they cover basically all of the tumors that we looked at in the 1,000 tumors would have at least 2 of the peptides correlating to their tumor. Okay. So it's unlikely one tumor is going to have all of the 16 markers. And we designed it as off the shelf. We actually debated this a lot, whether or not we would do individualized vaccine versus off the shelf. The reason we settled on off the shelf is because one, the turnaround time is faster to make sure everybody gets treated as soon after radiation as possible. But also there's such a finite number of genetic alterations that if we had this pool of peptides, basically every tumor we chose at random from the study had at least 2 of the markers in the tumor. So they would all be likely to have some efficacy from it. What we didn't want to do is give the vaccine, allowing patients not to be biopsied, and then find out that half of them didn't have the markers. So with what we know, we think we're covering the vast majority of tumors, even if they don't have every single peptide.
I have questions for my husband. So have you seen in animal models using this vaccine an effect on TIL?
Increase of TIL.
Increase of TIL.
Yeah, so we actually don't have a good model for using this in mouse models. Some of the issue stems around the fact that the mouse immune system doesn't mimic human immune system as well. And then in order to have what we call PDX models, or basically mice that we've implanted human tumors inside of their brainstem, basically we have to use nude mice for that, which means they have no immune system to be able to accept a human tumor. So we're limited because of the models that we have right now and not being able to study that specifically. we basically are using the fact that in adult tumors, when they've chosen antigens in the way that we have, or these tumor markers in the way that we have, they've seen that they have tumor infiltrating lymphocytes, which is the TIL, after the vaccine. So, we're still in a world where we would love to have better preclinical data for some of our studies, but we think even though we're extrapolating in some areas, that this is likely to increase tumor-specific immune response in the tumor itself.
You should try some xenografts. You don't need to use nude mice for all these studies. Obviously, the nude mice will be the choice for it, looking at the original development of the tumor.
Yes.
And how the activation or lack thereof of thymocytes when the tumor is developing. The nude mice are critical for that.
Yeah.
But you could certainly at this point it's kind of a sort of a moot point to go back and do the assays again. So thank you.
Yeah, thank you.
Thank you.
Ashley, in some of the CAR T cell studies, I think they're finding that there's some myeloids that are now keeping the T cells from continuing to proliferate and so forth. Is that a concern also with the vaccine, or totally different? I apologize, I am not a scientist.
No, that's a great question. There are so many different mechanisms that tumors can use to evade the immune system, one of which is these tumor-associated myeloid cells. So we still kind of haven't flushed that out. If the CAR T cells are continuing to show that, that might be an issue with the vaccine as well, because it also is working through the T cell system and the T cell response to that. We're hoping that by keeping the T cells going by blocking these off signals simultaneously, that we'll be able to overcome it. But that is something that we want to look into for sure.
I know that my son was in the Stanford trial and donated his brain, and that was maybe a bit of a surprise, not complete surprise, but it was information that they were thrilled to learn from the tissue because of the myeloid depleting medication that could be given. Is that anything that could be added if it becomes a problem?
Yeah, I think that likely what the FDA will say, we might be able to do that in the future. One of the big problems with getting this trial through the regulatory is already trying to combine things up front with the checkpoint blockade molecules. So I think we would have to do that stepwise. But I think if enough of us are showing data, that would be something that we could convince them of. But right now, even Avastin as a use for like anti-swelling wasn't something they wanted us to add in because we already had so many new agents at once.
Thank you.
Dr. Plant, I'm a former patient, or I'm not. My son was Stu Goldman. My son was Joshua McFadden. We were with Alicia Lunson as well. Not incredible lady. Are you guys doing steroids with this? I came in, I was having internet issues. We just moved.
No, both of I only got to work with Stu for a short period of time is one of the reasons that I had come to Lurie Children's to begin with. So he's amazing and a big loss for us.
Yeah, huge loss.
Yeah. So in general, we do allow steroids. Steroids directly take out the T cells, so not ideal. We realize that in some situations, patients can't get off the steroids. And so basically we've just said that it has to be at least below a certain level. But the goal would be, and we'll work with, primary doctors, who have patients who want to go on this to try to see as much as possible getting off of the steroids, or at least to a very low level. We know even with a little bit of steroids, the lymphocyte count, which includes the B and T cells, are low in most patients. So it is something we think will work against us, but we also have to balance the fact that radiation might be worsening symptoms for some patients, and that they need that to maintain good quality of life too.
So I heard you say that you're not requiring a biopsy, but what if a child through the MRI is not 100%, then will you, or?
Yes, so the lack of biopsy, so the only ones who can get on who don't have a biopsy have to have totally classic DIPG on the MRI, including their doctors saying they feel like the symptoms fit, the imaging fits, and there's no question about that. If there is a question or something's atypical about the imaging, then the biopsy would be required. And mostly that's because some of the atypical imaging characteristics might be because the molecular alterations in that tumor are different, and we want to make sure that we're not giving them a vaccine that they're not going to respond to. There are some, as you guys know, non-histone mutated DIPGs that fall into different subcategories of high-grade glioma, and they might not have the peptides that we have in our vaccine at a high rate. And so we wouldn't want to expose them to something that might not work, and we would want to direct them to a different trial.
So I'm not in any foundation. I'm just, like to hear what's updates over. I mean, it was just 5 years for us. And Joshua was 11 and 12, and he insisted on donating. As parents, we didn't know if that was the right thing to do, but we granted our child's wish.
Yeah.
Our understanding, though, is like they froze a lot of Joshua's to use for you guys to use.
Yeah.
Many states, I mean, it's all over the place. So with all these people who are continuing to donate, do you feel like you're getting progress, or?
Yeah, I definitely think it has, really families of children with DIPG, whether through the tissue donation process or the initial studies that allowed us to biopsy the ponds when we didn't know if it was safe, really are the engine behind all of the research that is today. I think I looked at clinicaltrials.gov just for my own information about how, since the biopsy trial, how many trials have had eligibility for DIPG, meaning we're open for patients that have DIPG, and there's almost 70 trials. For tumors that are only 200 to 300 cases per year, the fact that we had 70 clinical trials directed at it is just basically a miracle in the medical world in general. And then even, my trial in particular, I didn't know if I could pull it off without it being industry sponsored, and having them fund the trial. But all of, the different families and foundations really wanted to help me move forward with this and not have lack of funding be a reason why we didn't get the vaccine forward. So I think the power of families and legacy of these children is really what has gotten us to where we are today. I think, the CAR T-cell experience has moved forward really quickly from preclinical to where it is today, and having more information about that. That's really allowed us to move forward other immunotherapies. And then the sequencing that we got from these tumors has really allowed us also to think about targeted therapies. So the blueprint study that we have is targeting the PDGFRA change. And so, really it's just an explosion of new ideas. Obviously, we'd like the first one we try to be the successful one. So we're still kind of waiting to know for sure what direction that is. But if there was ever a time, I think that it's now. In general, for our legacy donations, I don't know if you know Xiaonan Li at all in the lab at Lurie Children's.
Me?
Yeah, so some of her.
No, I don't know any, because I'm not, we're actually in the process, we literally just moved yesterday, and we we are actually trying to move to Florida right now.
Oh, wow.
My kids are in college. I have two kids who are pre-med majors, and their goal is to be into oncology. I mean, the stage when you're in college. So, I mean, I just want to make sure I am, before they head this route.
Yeah, no, definitely. That's the same reason I talked about early on in this talk that I went into this field, because I had cousins that had pediatric cancers when I was really young and knew that's what I wanted to do. And I think the research is very meaningful if that's what they want to pursue. The reason I just bring up Xiaonan Li is he is based at Northwestern, but one of the Lurie Children's faculty, and he receives tissue from all of our legacy donations and is in charge of all the animal models. And he now has, I think, the largest animal models for pediatric brain cancer basically in the nation. And so people are coming to us to basically use and borrow some of the mice for their own studies. So it's really just exponential, the effect that, having that tissue, does for the research community and for fighting DIPG. So I think it's amazing that you guys were able to do that.
Yeah, are you still working? Is Alicia working with you on this? Because I know she was doing a different trial 5 years ago.
Yes, so we are both the clinical trialists. That's what we call ourselves, the team, which just means we're trying to get new and innovative therapies off the ground into phase 1 trials by working with all the laboratories and trying to translate that information into clinical trials as fast and as safely as possible. So she's been working on other things, but it's definitely going to be a big part of this study as well.
Well, tell her I say hello. I sent her an email, bounced back for some reason in January. So
okay, I definitely will.
Yeah. So I'm remarried and she knows all this, but it's Joshua McFadden, and trust me, the whole department knew Joshua. He was very verbal to Stu.
That's great. He can
So yeah. Well, thank you for your help.
Thank you.
Do you have anybody enrolled yet?
We have one patient scheduled to start the first week in April. So there's a little bit of lag when families are interested because it's 6 weeks after radiation. So that patient's still in radiation. And then we have 2 others that are interested who may start soon after. So hopefully we'll get past the hurdle of the older age group and make that available for the younger age group too in the near future.
Cool, good. We all look forward to hearing that and hoping it works the best. Thank you for being here.
Guys, I appreciate it.
Does anybody else have any questions? No, well, Dr. Plant, thank you so much for joining us. It looks like the trial is basically kind of starting April 1st. So we are going to keep you in our prayers, and we're going to hope for the best, and we're going to root for you that this is the magic bullet, if that's not too cliche to say. And so thank you so much for joining us today. Thank you for your time. Thank you for your research. Thank you for everything that you do for our community. I can't thank you enough, and I can't tell you how honored we are to have you here. I'm gonna try not to cry for all of for everything that you do for our community. And one thing that we are working with Tougher together too is we are trying to help parents get to clinical trials. So if you reach out, if you let your social workers know to reach out to the Mark Jr. Foundation, we'll try to help them get transportation and housing and things like that too. So if you have anybody who needs that support too, we're here to help, or just anything at all, we'll do what we can to help the families. So yeah, I don't know, does anybody else have anything to say? I think Lisa is still on the phone, and I just wanted to say thank you, Lisa, for inviting Dr. Plant. This has been amazing. So thank you so much.
Absolutely. Dr. Plant, we just can't thank you enough for being so open and transparent to discuss the trials. As parents, it's always a little bit scary to be one of the first to try a trial, but having just this open conversation, being able to hear, here's what we know, here's what we might not know, but here's what we think, is so helpful. And if I understand the parents that came before us, even by a few years, that wasn't always the case. So we applaud you, and I echo everything Lynette said. Whenever you need something, please reach out to the community.
Thank you guys so much for having me, and thanks for all you do and supporting the families. I didn't even realize this was out here, and this is really wonderful. Thanks for taking your time too to support everybody. And let me know if anyone wants to contact me. I'm available by email and happy to talk.